Next, we will have the last talk for this session, and this talk will be given by Dr. Siow Yan-Chin. Dr. Siow is a palliative care consultant at Park City Medical Center, and her interest is in training and education. She was the project lead for the discharge guidance for patients with prognosis of days for palliative care unit in Selayang Hospital 2019, and also contributed to the writing of the subcutaneous management guideline for palliative care unit in Selayang in the year 2020. Today, she will be giving us a lecture on rapid hospital discharge for end-of-life care, the current practices and future direction. Please welcome Dr. Siow.
Very good afternoon to all. I would like to take this opportunity to thank the Malaysian Hospice Council for the opportunity to deliver a talk on this conference. I'll be talking about rapid hospital discharge for end-of-life care, current practices, and future direction. I'll be covering various terminologies of rapid discharge, its definition, challenges, why rapid discharge is provided, current practices, and the future. Looking at various literatures, different centers over the world call rapid discharge at different names. Some are called fast-track discharge, terminal discharge, such as in Singapore and some centers in Malaysia. And in my hospital at Park City Medical Center, I would like to call it HOPE, Hospital Discharge Planning for Patients who are at end of life. A colleague asked me some time ago, can it be called a discharge? And we know for the fact in various hospitals, without palliative care services, it is called at own risk discharge, whereby family sign an AOR form and they are left to handle the discharge and care at home by themselves. For the purpose of this talk, it will be called rapid discharge. It is an emergent procedure, a procedure with some urgency for patients with expected prognosis of hours to days in hospital to return home. This definition is taken from Gambles et al. And Chong et al. Rapid discharge is time critical, as the name suggests. At Selayang Hospital, from the time of decision to bring patient home till the actual discharge takes about 3 hours. At an oncology ward in a tertiary hospital in Singapore, it takes 6 hours. And in the University of Liverpool, 6 hours. Often, the palliative care team organizing rapid discharges do face with various challenges. Why is there such a rush in time? Often we see family members, yes, they agree with patient that the preferred place of death is home. However, they are not ready to care for patient at home. And so they wait until the very last moment to request for a rapid discharge. Uncertainty in prognosis, such as for non-cancer patients, and of course, some late referrals to the palliative care team. Rapid discharges also happen in a very sporadic nature. In as much as we would like to plan, it could happen quite sporadically. So it does disrupt the ward routine. Providing a rapid discharge involves a lot of complex coordination with the various team members of the unit, medication, transportation, the documents, the forms, and handing over to the community team. Why rapid discharge? We know that many Malaysians prefer to die at home. According to the survey done by Hospice Malaysia in 2015, 61% of those surveyed indicated home as the preferred place of death. In Singapore, we noticed that 77% preferred to die at home. So, providing rapid discharges is to honor patients' autonomy and preference. Is an indicator of good death. It has its religious importance. Some Buddhist patients required that the body do not be touched for at least 8 hours with prolonged chanting and prayers. Dying at home, some may believe it will help the spirit to be at peace. Dying at home also has some cultural and family importance. It helps family members to fulfill their filial obligation, and it could also be a meaningful private time for the family. Current practices. If you search for rapid discharges online, you would be able to find some of the workflows, recommendation, guidance from various institutions. I'm going to use the rapid discharge guidance by Palliative Care Unit Selayang Hospital to highlight some of the key components in a rapid discharge. I had the opportunity as the working group to develop this guidance. Just an overview of the index of the guidance. We do talked about in general the objectives, definitions. Highlight is given on the roles and responsibilities of the various team members so that everybody could be very clear of their role, and the hope is nothing important is missed during the rapid discharge process. The key issues that I will go through in more details later, and it also involves checklists as well as the various forms and letters. So the first key component is communication. Issues talked about involve prognosis, or what to expect when a person is dying, information about symptom control, the issues of nutrition and hydration are addressed, oral, eye, skin, and bowel care are also talked about. A second area that is addressed in this guidance is on medications. We know most of our injectable medications used are categorized as DDs, and it's being governed by the poison regulation. So we would like to make sure that all the regulations stated are being followed, such as the regulation on possession of psychotropic substance. We make sure that it is followed. Family member possessing the psychotropic substance for administration to a patient must be done in accordance with the direction of a registered medical practitioner. That goes the same to administration. Record is very important, that they need to keep a register of the medication used, name, strength, time, or when it's being administered. And all of this need to be documented. And so for all patients discharging would have a medication diary that talks about the indication, the expected onset of action, and how often they could repeat, and how soon they could repeat the dosing. Information on storage, disposal, return, and refill, a more specific dosages and frequency of the medications. And here is a diary for family member to document that date and time of administration. We know that over a short time, much information is given to the family members. Also provide written information on a brochure. Care kit, forms and documents. We have a form, agreement to care form, which mainly summarize that the family members understood that they have their responsibilities to play, that they will administer, document, store, and return medications according to instruction. And if they have doubts in terms of medication administration, they could always contact the palliative care team unit. A memo for police officers with information about the number of syringes and the medications possessed as prescribed, as well with the diagnosis of the patient that could be used for further police documentation after the patient's death. And of course, very important, the handing over of care and information to the community care services. And this is done via a formal referral and a phone call handover. Patients who leaves not under any community service coverage will be followed up by the palliative care unit via phone consultations. Checklist. So to some doctors, they find it really useful to have this checklist to help them not forgetting the important points to be addressed. So that's all on the rapid discharge guidance. Next, we talked about some of the challenges I heard from the community care providers. In terms of rapid discharges, those that are not reviewed or referred to the hospital palliative care team may cause a lot of issues because many of the important communications are not done and much explanation is needed. And so much time is spent to address family distress. And next we could see, according to Chong et al. In their studies, they find that after a rapid discharge, patient needed 3 times more service contacts from the hospice staff compared to their regular patients. 1.78 contacts per day versus 0.62 contacts per day. We'd just like to spend time talking about what happened to patients after rapid discharge. I know this is a very busy slide, but this is taken from Chong et al. And this is data from Selayang Hospital rapid discharge data from 2017. If we look at the 260 patients identified for rapid discharge, 31 patients actually died before they could reach home. And that is about 12% of the total number of discharges identified. Similarly, out of the 36 patients identified for rapid discharge, 4 didn't make it home. And so that constitutes 11%. Just to highlight, even with the efforts of discharging patients as soon as we could, about 10% of them actually don't get to go home. So according to Chong et al., 76% of their patients actually passed away at home. However, about 7 patients, and that is about 3% of the total number, actually do survive longer. And according to the Selayang 2017 data, we also see that 5 out of the 32 patients, that's about 15%, survive longer than a week. So that is the challenge that could be faced surrounding the issue of prognostication. If we look at readmission, that is something to be avoided, but we do see 4 readmission in the cohort of Chong et al. Versus 1 patient that is being readmitted by Selayang Hospital. Just some points for us to ponder. In some of the literature that I came across, cost saving was stated as one of the benefit for a rapid discharge, for us to understand that a day of hospital cost in a private hospital in Malaysia for end-of-life care with medical and nursing assistance may cost about 1,000 to 1,500 per day. And in the Ministry of Health hospitals, even though patients pay minimal amount of fees, but it actually do cost about 1,000 to 1,500 ringgit per day for a medical bed use. So being in hospital is costly. However, when we look at the possible cost involved in a rapid discharge, medication, depending on what setting, whether a government setting or a private setting, would cost hundreds. But elastometric bottle for medication infusion cost ambulance would cost a few hundreds depending on the distance. If a carer is hired, that could also cost 200 per day. And also equipment, rental. And how about the loss of daily income? If summing up all this, it could also come up to about 1,000 ringgit per day. So maybe it is not as cost saving as it is thought. There is concern that rapid discharges may encourage late palliative care referrals. Interestingly, looking at the data provided by Chong et al., and I probably need to mention the study by Chong et al. Is carried out in HCE, of the largest hospice in Singapore, that looks after 2/3 of the palliative care patients in Singapore. They find that of their rapid discharges, 76% of the referrals are new patients. And interestingly, the distribution of cancer and non-cancers are near equal, which is contradictory to their usual referrals that consist of 80% of cancers versus 20% of non-cancers. So could this tell us that patients for rapid discharge are coming very late? So I think as a hospital palliative care providers, on one hand, we will continue to advocate for early palliative referrals. On the other, rapid discharge services is needed and it needs to be done well. So as addressed in the earlier parts of this talk, the many benefits, as well as we do not want to leave regrets among the bereaved family members, as well the professionals, caregivers, because if the primary team, the non-palliative care team, are left to do the rapid discharge, there could be many areas which are not addressed, and that could really have a devastating implication to our patient as well as family members. Lastly, about the future. Rapid discharge does need research and quality improvement, and really looking at the end user to get feedback from the bereaved caregivers whom have utilized the service on the actual service. Do they think that patient has a dignified death? Do they think that all these are still worthwhile? Collaboration between hospital and community hospices, whether there could be crossing of palliative care providers, hospital providers doing home visits, visiting patients who are discharged, or community palliative care providers visiting patient and family before the discharge. And together in collaboration, identifying and addressing issues surrounding rapid discharge so that improvement could be done. So that's the end of my presentation. Thank you.
Thank you very much, Dr. Siow Yanqing. Yeah, I think a lot of different units now are moving forward with the plans of starting rapid discharge protocols, especially when there's an in-house palliative physician in those hospitals. I myself in Malacca have just started this a few months ago, and I think the response has been positive so far. All right, so I think we'll move on to the question and answers session in a bit.